We are?
Yeah, please. Yeah, because colleagues will just join. First of all, thank you everyone for joining and welcome to this exciting learning event on which I thought initially was a really dry topic of data, but somehow we've all managed to fall in love with it and understand the importance of how data can drive and improve outcomes for us. So warm welcome to everyone. And we'll just start with our first presenter or colleague who will do a brief introduction, which is Tim Butler. We have got 2 pre-records, and then obviously we've got Menti in the chat function, so we'll be asking a few questions, collating feedback and opinions from colleagues, and then having a bit of a discussion. And then hopefully on the back of this sort of learning event, we'll also try to produce some outputs or FAQs or some sort of discussion points in terms of where we take this event and what perhaps you found useful, what perhaps we could change, or how we could bring data into our working lives, whether that's as a commissioner, ICB, meds management teams, PCNs, practices, but more importantly, how we can use it effectively and efficiently, make it really easy, and make it business as usual for everyone. So that's just a very brief. Dan, if we can start with Tim, that'll be brilliant. Thank you, everyone.
No problem. Just before I share his presentation, just to mention as well, if everyone wants to please mute and cameras off just while the presentation is going on. It just helps with the technology. If you've got any questions, feel free to put them in the chat throughout. Bob and Waqas are obviously with us today, so they can be answering interactively. And Waqas, just a note for yourself, when we get to the questions and answers later, Louise will be watching the timings and she'll just let you know when you're getting close to your time. Okay, right, we'll make a start.
Hello, everybody. Thank you for attending this virtual conference today, looking at using diabetes data for the improvement of our care of diabetes. I'd like to welcome you. My name is Dr. Tim Butler. I'm an Assistant Medical Director for the Regional Office for NHS England, and I have the joy of being the responsible officer for the delivery of the diabetes programme. Next slide, please. This afternoon we have an interesting agenda looking at the various types of diabetes data we have, and we'll send you links and we'll share the data. I'd like to set the context for this and where does this sit regarding our diabetes today. Before I start, I will just talk about some housekeeping rules. We'd ask you to remain on mute, please. There will be questions at the end, so please hold your questions to the end. There is a chat box function, and please, the chat box will be monitored, so please you can add your questions or comments on the presentations in your chat box. There is also a raise hand function, which we will use for questions and answers towards the end. Thank you very much. Next slide, please. So setting the scene for diabetes, what's our strategy? I think really the strategy has to be said, we must have good clinical leadership at all levels. That means at GP practice level, our nurse leads, our PCN leads, our ICB leads, making sure that every department within the ICB knows about diabetes. It is approximately 10% of our NHS spend is related to diabetes and complications of diabetes. So we should have a focus on diabetes in everything we do. We need to decide how we do that through data-driven decisions, evidence-based practice that is driven by our data. We need an excellent comms strategy, increasing awareness of the issues, both professional and for the public. We need a professional education using webinars, learning events, developing the know-how to deliver. We need to work with our partners. That means local authorities, communications, both within and across organisations. We need to be working in our localities with our local teams, delivering a local service for our patients. We need to embrace technology and innovation. We have new therapies and new technology, which is putting a huge challenge on our systems, but giving us a huge opportunity as well. Next slide, please. The one graph that I have for you today is the overall prevalence of diabetes over the last 20 years. Back in 2005, the prevalence of diabetes was running at about 3.5, 3.6%. Now the prevalence of our diabetes is running at 5.9%. There is no sign that our increasing prevalence of diabetes is reducing. This is an enormous challenge and is putting an enormous pressure on our system. The only way we are going to meet this in any sort of smart way is to make sensible decisions using the data. And this is why we have data for diabetes. I was looking at US data. US data at the moment, 10% of their population is classed as diabetic. The UK appears to be following firmly in the footsteps of the United States regarding their diabetes prevalence. So we do have to be smarter and we have to be clever in how we deliver high quality services. Next slide, please. To do this, we have developed a number of diabetes dashboards and diabetes data sources. We've just put 6 down here that you can actually have access to. You can log in and look up your area. We will circulate these slides, and these are active links with this slide. So I would encourage you, please do look at this after the presentations today. If there's any other diabetes dashboards, data sources that people know about that aren't included, please do share them, and we will include them in our distribution of the slides. So I think that finishes my contribution today. I will hand over to Waqas, who's I think is chairing in my absence. I wish you well this afternoon, and I hope it is a good conference for you. And again, my apologies, I cannot be with you today due to annual leave. Thank you very much, everybody. Enjoy your day. Thank you.
Good afternoon, everyone. Welcome again, and thank you for attending this really exciting educational session, learning event for us on data. And it's a real privilege and honour today to invite Dr. Bob Young, who is obviously our national diabetes data guru, and we have the pleasure for him to be here today. So for the next sort of 15 or 20 minutes, just to give everyone a bit of a taste of what we will be doing, I think it's important to recognise that one of the objectives of today is to just gain a better understanding of what is the National Diabetes Audit Dashboard. We really want to showcase how we can make data both easily accessible, meaningful, but more importantly, simple enough for us to use in our day-to-day practice to gain actionable insights to improve outcomes and service delivery across primary care, community care, and obviously secondary care services across our regions. So we're going to go through various different views. As you can see, one of the earlier views there is highlighted as Tim's view. So Tim is our regional SRO for diabetes as well. And the idea behind this is that we would like everyone to imagine that Tim is having lunch and he suddenly has an impulse to quickly gather an overview of how diabetes care is across the region. And from there, you can then see we'll drill down to what that looks like for an ICB. So myself, I'm an ICB clinical lead, so that'll be very interesting for me to see how we can compare places within an ICB. And then it's more practicalities, how we drill this down to primary care within the PCN and within practices, and also not to forget our secondary care colleagues. So how can we look at services in terms of their outcomes, how they are currently delivering care, comparing different services across our region with each other, and really to pinpoint where perhaps we could do improvements all through the eye of data. And once again, it's a pleasure to have Bob here today. Bob, it's over to you, please.
Well, that's a very kind introduction, Waqas. So just a couple of slides on why use national data? First of all, next slide, please. So there are some benefits in using national data. There's efficiency of collection, there's quality assurance of the data, there's the opportunity to link national data sets to create a bigger picture. There is benchmarking, so if it's truly national and comprehensive, you can compare yourself with anyone in the country. There's trend analysis to work out what changes are delivering improvements. There is the exposure of disparities because there are big enough volumes to pick up the effects of ethnicity and deprivation, etc. And there's the opportunity, hopefully, and most importantly, to identify and share success factors. But there are frustrations in using national data. There can be delays between the data being gathered and it being accessible. And then there are the ways in which it is presented. Next slide, please. So in an effort to try and improve this latter step, the NDA started a program of producing dashboards in spring 2022. And the link to the dashboards landing page is there in the slide. There are now 9 dashboards covering the totality of diabetes care, from prevention through routine care to the various specialty subgroups. And the aim of the dashboards is to make the previously published spreadsheet data more timely and more accessible to all the users. That is, professionally, GPs, specialist services, ICBs, regional and national teams. That's about 8,000 users if you count them up. And then, of course, people with diabetes. And this should be regarded as a work in progress. And the aim is that the development of the dashboards should be user-driven. So today we're going to give you a quick run through what's there at the moment. I think a lot of it is beginning to be usable and helpful, but it is a work in progress. Next slide, please. So I'll jump into this next section, which is what we've called Tim's view. Now, at a recent meeting, Tim threw down the gauntlet and said he wanted a simple view of all the things that were really important to him, and he didn't want to be going fiddling about with lots of buttons and different clicks. So I have imagined that Tim is sitting having a sandwich at lunchtime, and he's going into the core annual dashboard, and he's going to have a look at what's happening at all his levels of responsibility. So this is the core annual dashboard landing page, and you click on the little icon at the bottom to move into the dashboard. And I'll talk a bit about the icons down the side as we go through. So on to the next. So he goes into, you'll see on the left-hand side, a little red circle around the main tab. And he's selected over on the right, another red circle, type 2 and other kinds of diabetes. And at the top there, this is the England view. And he's got the numbers of people with diagnosed type 2 diabetes in England at the top. And then in columns down the left and the right, the individual care processes and their performance in 2020-21 and then 21-22. And then in the central panel, it shows you what has happened between these 2 years, 21.2%, all 9 care processes up to 37.3% over that year. Next slide, please. So this is just to talk a little bit about the icons down the side. So the main views are the top one, the main one that we've talked about, then demographics, then organization, and then performance. And we'll use some of each of these as we go through. This is the treatment target view of the same landing page, the main page of the core national dashboard. So this is just a little bit of national picture. So in the next slide, we show you the filter menu. So having started off with a national picture, Tim can now select, and I won't go through this tediously, but he can just go from one step to the next by selecting from these different tabs, selecting the region, then the ICS or LHB in Wales, then selecting the PCN, then selecting the practice, and he can divide by males and females as well if he wishes to. So first of all, he selects the Northeastern Yorkshire region, and this is the same view that we looked at before. So this is type 2 diabetes, comparing care processes for 2021 and 21-22. So there's a picture there for how the Northeastern Yorkshire has done over this particular year. And then you can click through on the filter to the next slide, which takes him to the Northeastern Cumbria ICB, which is the one where his PCN and practice sit. Again, looking at the same view of how the care processes have changed over that period. And you can see that there's a bit more change in that ICB than in some of the others. Then in Derwent-side PCN, there is again an even greater change. And going on then to Tanfield Medical Group, which is where Tim does his clinical practice, he's got a picture of how things are working down at practice level. So just by using these filters, he can take the same data set and look at it at all the different levels. Then if you move to the next slide, he might want to compare the region, the ICB, and the PCN. So he goes on the left there, you can see in white the organization tab, and that allows him to compare at the top left the different ICBs in the Yorkshire and Humber, then the PCNs below, and that scrolls so you can look at comparison between all the PCNs, and on the right looking at the picture regionally and how the Northeastern Yorkshire does in comparison to the other regions. This particular selection is for type 1 diabetes, you'll see on the top right. And then you can use this organization tab to get a comparative picture of your individual PCN or surgery. So you can also look at it by place. These codes are the old CCG codes, and within each of these there are the composite PCNs, and then you can open up the PCN and you get all the practices within the PCN. Again, looking at type 2 diabetes in this one, all care processes, all treatment targets, and you can look at it by type 1 or type 2 diabetes, and you can see the tabs along the top. You can do various bits and pieces with those as well. So that's what Tim can do before he's even finished his first sandwich. He's got that view at different levels. Now, it's not like a data pack. You do have to click through, but it perhaps just illustrates the different levels of interaction. Lakis, did you want to say anything about this before we move on to the next section?
Absolutely. I'm just going to ask one thing, Bob. I think that's really interesting how you've sort of shown us how you can drill down and the numbers change across regions and how you can drill down, which is really easy and it's quite intuitive. You know, it's within a few clicks you can get down to the data that's meaningful to you. My only question I had, Bob, was that one of the questions which I hear a lot across the regions when we have discussions around data is any improvements that you will do across your regions, it's only as good as the data that you're given. And I was just wondering, in terms of, it might be useful to share or highlight in terms of how, let's say, how often the data's redistributed and what's the lag between the data, because obviously we're looking at on these slides 21, 22, and what's the data cut for the new data that we get.
Okay, so the data in the core national dashboard is the data for 21-22, the latest data there, from both primary care and secondary care, integrated into a single picture. There is a more frequent data collection, a 3-monthly data collection, that is reported in the core quarterly dashboard. And when we come to talk about data from your neck of the woods, Lakis, we'll use the core quarterly dashboard, and that takes you up to about 5 or 6 months ago. So when we're looking at that, we'll be looking at the whole of 2022 up to the end of December 2022. So there are, the normal cycle is that the core quarterly is updated quarterly and reported about 4 or 5 months after it's been collected. And for the core annual dashboard, that's an annual collection exercise with the data cleaned over the summer and published as early as possible in the autumn as it can be. But that means that it's sort of 9 months or so behind the data collection. So it's yeah, there is a timeliness issue, and
no, but that's really reassuring. Yeah, that's really reassuring, Bob, because it's not old data, it's recent data, so it's actionable intel. So that's good for colleagues to know. Right, and we'll go through the ICB view. This is probably what I'm more interested in.
Okay, so we're going to just take some views from the core annual dashboard, from the type 1 dashboard, from the NDFA, that's the foot care dashboard, and from the complications and mortality dashboard. So first of all, I've just taken panels from 2 related sections, one on the left for type 1, one on the right for type 2. And this is showing the regions, and then in the bottom panels for care processes and treatment targets. And in the top, you've got the Northeastern Yorkshire, so you can easily see how that compares with the others and with England. So let's move on then. Just perhaps mentioning, if we just look at the Northeastern Yorkshire at this level, all 8 care processes in this latest year, 37.4%. That's really good, and much better than the northwest of England, which Oh, you've moved on. Okay, we'll move on to the next slide. So here we're looking at the ICBs for type 2 diabetes, care processes, all 8 care processes. And you can see that the trend over the past 5 years has been one of deterioration. But all of the ICBs are deteriorating at a similar rate. And there was, of course, the particular drop at the time of the pandemic. Next slide, please. On the other hand, if you look at type 1 glucose control, that is gratifyingly improving. Well, it's quite interesting to look that although care processes were deteriorating at a similar rate across ICBs, glucose control has improved at different rates across the ICBs. So from 9.3% in Humber and Yorkshire to 4.9% in West Yorkshire. Next one. So we've got now another view that allows you to compare the regions, first of all, showing that this problem with a deterioration in care processes in the bottom right-hand panel is true for all the regions. And you can see how the northeastern Yorkshire fits in to the picture there, with a variation between regions between 41.3% and 52.5%. So next slide, please. So then you can drill down from that to the ICBs within the Northeast region, and you can see that there is some variation from 47.1% to 52.1%, and the individual care processes are illustrated in the spider diagram on the right. Next slide, please. So then you can drill down from that to all the PCNs in a particular ICB, and you can scroll along and see how much variation across the PCNs in the northeastern North Cumbria ICB. There's a variation between 24% and 69% in the achievement of the 8 care processes. Next slide, please. And then we can go to Derwentshire PCN. And again, we're looking at type 2 diabetes, 8 care processes, and the variation's gone up again from 32.4% to 83.3%. So if we do a similar exercise, moving on to the next slide, between the 3 treatment targets, you can see there's actually much less variation between the ICBs in respect of 3 treatment targets. And you can drill down with that as well. But just if we move on to the next slide, I've pulled out various views from the demographic section. And you can view this at any geographical level, but here we're looking at the northeastern Yorkshire region, and you can see that the care processes in the top left-hand panel don't really vary much by ethnicity. In the top right-hand panel, you've got age, and I've just highlighted there the growing young type 2 population. Look at the number of people under the age of 40 with 29 to 39 with type 2 diabetes, sorry, 20 to 29 with type 2 diabetes. big increasing population. And then in panel 2, that's the top right hand, and panel 3, the bottom left, you've got an inverse association between age and deprivation and achievement of the treatment targets. And you can see that the slope of that association is greater for age than it is for deprivation. Next one. So this is using the type 1 dashboard and comparing the ICBs, and across your region, the 4 ICBs have got very similar use of technology. And the top right-hand panel shows that there isn't much variation on the right associated with age, but there's substantial variation in the use of technology with deprivation. The next slide moves on to foot care. As a region, yours is in the top quartile for healing ulcers, but there is some variation within the region from 47% up to 53%, so a bit of variation, but nothing like the variation across the whole of England. And but there is a notable high rate of severe ulcers in the South Yorkshire area. And then the final slide in this section is just looking at admissions for complications in people with diabetes, stopping just before the pandemic so as not to be influenced by that. And you can see that the number of admissions has gone up by 10% in 6 years, and that's being driven by admissions for heart failure and for CKD. So that's just a quick skip through the sorts of data you can get relevant to making decisions at ICB level.
Thank you, Bob. And I think that's really, really useful, because it's not just looking at numbers or care, but actually in this newer version, it's actually been able to give us insights into how we address both how we look at disparities, but also how we address the health inequalities, whether we think that's down to deprivation, different ethnic groups, or age as per se. And I think also more importantly, which I really like, is the last 2 slides, one around tech, because as we see with changes in NICE guidance and also commissioning policies across regions, there will be movement, or let's say more access to technology for people both with type 1 as well as type 2 diabetes, particularly in primary and community care. So it'll be interesting to see how we support access and uptake of technology, but at the same time we don't widen this health inequality gap. So I think that'll be very useful for us, particularly across West Yorkshire, as we and push out our CGM or commissioning or technology policies, that we're mindful of that. So that's brilliant, and thank you very much for that. Next, I think you're going to take us through, is it primary care?
So this is primary care, and I found an interesting PCN called Affinity Care PCN, which I thought you might be interested in, Rakas. So if we just go to the first slide in this section, I mean, you just jump in at any point, but this, taking the main tab and Affinity Care PCN, this is looking at type 2 diabetes, care processes, and what I've done here is selected not from the core annual dashboard, but selected from the core quarterly dashboard. So this is the data up to the end of December 2022, not to the end of March 2022. And it's comparing 2021 with 2022. And you can see that Affinity Care PCN seems to be making good progress between those 2 years. This is the demographics tab. So we've gone now to your practice, Bacchus, and this is showing the age groups in the practice, and the completion of care processes for people with type 2 diabetes in the different age groups. And in fact, you've probably got slightly less age-related variation than we showed in that regional data. And then you can move on there in the organization tab on the left-hand side. You can see that. So Affinity Care PCN, and you can compare yourself with the Care Board average data, with the North East and Yorkshire average data, and with the England data. And then you can take the individual practice and look at how the practice is doing in the next slide compared to other practices for all 8 care processes, all 9 care processes, and then you can click through. So by clicking on the practice and looking for key messages drill down, so you just click on that, you move through to the next slide, which shows you by individual care process and by individual treatment target how you're comparing, in this case, to the English data. Now, the intermediate columns should be completed as well, the PCN, ICS, and region. And I don't know why that's not coming up at the moment. But this is January to December 2022, and you can see that as far as your practice is concerned, Bacchus, you're doing better than England, but there are certain things that are holding, certain care processes in particular, that are holding you back. And on the treatment target front, you're generally doing better than England as a whole. But what you'd like to see is the intermediate levels as well, which should be there. And I've sent in a query as to why they're not there. And of course, if you've done this before the latest one, if you move on to the next slide, it shows you if you've done this in March or February, it would have shown you this, which is the data up to the end of September.
That's excellent, and I do have to say, Bob, I really like the spider webs, because it's very visual, and straight away I think it draws your attention, and I think it's just an easy way and a more simplistic way of looking at data rather than lots of numbers and percentages and points, which we have that at the bottom as well. But I think the spider web, it's a bit like insights on a page, so I really like what you've done with that from a user experience point of view as well. Clearly we've done some work on it, but we've got a long journey to go with diabetes care improvements across our PCN, but that's fascinating. Thank you.
So that's for practice, and hopefully there's quite a lot there that you can even look at how your practice is doing by comparison with all the other practices in England, as well as if you just want to compare yourself with the practices locally. So there are lots of things you can delve into if you want to get a some details. So we'll go on what can the specialist services get. So we'll take a brief look at Type 1 dashboard, the adolescent and young adults dashboard, the foot care dashboard, and the pregnancy dashboard. So if we take, first of all, I've taken 3 panels. Now the Type 1 dashboard, you might say, well, there's Type 1 data in the core dashboard. That is true, but the Type 1 data in the Type 1 dashboard has been validated to a greater extent. So not only coding, but also medication. And there'll be a young Type 2 dashboard coming up out in the next few months. And that again will have validated diagnosis of Type 2 diabetes. So that's just a little wrinkle in these. But this is looking at the specialist services that have submitted to the NDA, and not all specialist services are able to because they don't all have electronic records. But quite a lot of specialist services in the Northeast have submitted, and you can see from the top left-hand panel some variations in achievement of glucose control targets. You can see in the bottom left-hand panel some variation in the use of insulin, different insulin regimens, particularly the use of pumps. And in the bottom right-hand panel, you can see differences in the deprivation profiles between the different specialist services. Moving on to the next slide. This is the adolescents and young adults slide. And what this does differently is take individual years accumulated to look at the impact of age. And this is showing the 4 ICBs. And what you can see, although there's some difference between the ICBs, there's a similar trend, and that is that glucose control and rates of ketoacidosis start rising at around 10 years old, and then they peak at the end of the teens, and then slowly improve, but never to the same level as achieved at 10 years old. You can see that the demographics of these young people between the different ICBs varies quite considerably, with particularly in the rates of severe deprivation. And across the nation, of course, there isn't any substantial variation in deprivation between for Type 1 diabetes, unlike Type 2 diabetes. So then moving on to another bit of the foot care dashboard, and this just allows individual specialist services that are delivering foot care to compare themselves against England and to compare themselves against each other over time. As you look at the different foot care services, you can see the trends vary, but as I also already mentioned, on the whole, foot care services do particularly well in your region. And finally, we've got pregnancy. So on the left, Type 1 pregnancies, on the right, Type 2 pregnancies. The different sections cover different key metrics. There's a variation between services in most of the measures, but perhaps the most notable thing is now that type 2 pregnancies are more numerous, very much more numerous, 465 as compared to 290. And that's a complete turnaround over the past 10 to 15 years.
Thank you very much for that, Bob. And I think it just highlights that there is a lot of data out there, but how you and the team have actually done an amazing and fantastic job at actually, I'm going to say, cutting the data and making it meaningful, and very reflective of what's important for us in clinics. From a commissioning standpoint, where do we need to plug the gaps? How do we gain more insights, whether that's around health inequalities, around improvements, particularly, for instance, if we look at transition of services as well. It was brilliant to see that we could actually see year-on-year data, so within that year, which actually might make us think we need to look at the problems a bit differently as well. But really good insights into it, and thank you very much, Bob, for joining us today and giving us these useful insights, and hopefully now we'll break off into brilliant. I think next we have is the Menti section, so if colleagues can kindly just from the chat box, if you just click on Menti, there's a little code, click on the code and it should take you to the Mentimeter screen, where the first question is around the NDA dashboard. So once you've answered it, we'll just upload the questions on the screen for everyone to see, and then it's followed up by another few questions. Dan, if you want to load up the first. Thank you.
Yeah, just bear with me. One second,
awkward
moment.
silence.
I know. I'm just setting the questions so that people can work through at their own pace. Okay. There you are.
Perfect. And I think is this section for me and Michael.
And Bob?
Oh, lovely.
Anyone to chip in? Yeah.
Yeah, no, absolutely fine. So we'll just give this another 30 seconds. So we can see almost half of the colleagues on the call, or less than half, are using the NDA dashboard. So hopefully one of the, I think the first learnings from this is just what data is available there. And again, the purpose of Bob and me doing a duo was just in terms of we all have different needs when we look at data, and we're coming at it from different angles, if we're based in primary care or secondary care, or if we're involved around commissioning or service delivery or changes of models of care. So we all have very unique, specific objectives as to why we're looking at the data. So I think one of the things which I'm sure colleagues will agree on is you can see from the data, you can use it at multiple levels with lots of different facets around it. And I think one of the key things that was definitely new for me and was not necessarily how you can chunk it down, but actually if you wanted to look at service delivery across a region with multiple hospitals, you can start actually benchmarking that and actually having a look, which patients perhaps are going to which services and how the service delivery is across different settings as well. So I think it's a good marker from a commissioning point of view, but also understanding where our gaps are, where perhaps we could do different improvements, and where you could have that holistic multidisciplinary team approach to looking at data and understanding and tackling the problem together. So I think hopefully after this we'll have definitely more colleagues using it. Michael, any comments from yourself so far?
Yeah, I suppose it's clear that there's a whole range of different ways in which people are using it. Be really keen to hear from people about how are they using the NDA data? What can we learn from that? I should have said that I'm the quality improvement lead for the NDA, and really just to try to share best practice in terms of using the data in different ways. So really keen to hear from anybody who is about how people are using the data.
Thank you. And Dan, do we have this? Is this second question or?
Yeah, so can you see the slide how you're currently using diabetes data? Yeah, so that's the question we're looking at first.
Yeah, I think it's very obvious. I think keywords, I think two keywords stand out, which is quite interesting. One is around monitor and audit. So from that, I'm assuming quality improvement, benchmarking. And then another big word there, which it's a good contrast, I guess, is where people are probably using it sporadically. So I think the idea is some are using it and using it well. And then we've got some colleagues where, like you say, it's, I'm going to say light touch. And from what I can see there, but there's loads of different areas and different teams are using it in very different ways. Michael, what do you think?
And we see comparison and comparing there. So it's curious as to what people are comparing against. Are they comparing themselves against the national picture, the regional picture? Are they looking against a team that's just down the road to see how they're doing compared to them? Are they looking for teams who are perhaps performing better and reaching out to those teams to say, how are you delivering book care or whatever it might be? So yeah, really keen to hear back from the teams more than is possible in the Menti.
Yeah, shall we move on to the next?
Yep.
Next Menti question. We got about I think it was 80 responses to the last one, so only on 43 for this one so far. So
we'll give it a few seconds.
So yeah, see if we can beat the 80.
Interesting.
I suppose it's difficult to know what makes it easy or difficult to use if you're not using it or if you're not using it regularly.
Yeah.
And we saw in the chat, people asking for where they would get hold of the data. So again, hoping that this has helped provide some of that information.
Yeah, I absolutely agree, Michael. And again, one of the things was around knowing what to use when. And I'm hoping that from the webinar, that's become very clear that I always say there's no right or wrong way to use it. It's just how you use it and what you see through it. And then once you've identified something, what your next steps are to either, like you say, monitor it or put some QI work behind it. And I think one thing that really stands out in the middle there, which I'm assuming is one of the things that makes it difficult for us to use data, is time across all of these different things that we're doing. So again, I'm hoping that, as you can see with the very clear functionality and the sort of tabs on the left hand side where we're just pushing one or two different buttons and it should quickly drill down within a few seconds or a minute or two to the specific question you're looking for in the data, and hopefully it answers or unearths that as well. But obviously mindful of colleagues being very busy in clinics and doing lots of different things, so hopefully this makes data a bit more easily accessible. But also, like you say, is what I like is that quick glance. You want to look at data and quickly build a picture in terms of what is it telling me. And that's why, for me personally, the Spidergram really was data on a page. It tells me how I'm doing at the moment and perhaps where I need to be better. I'll welcome comments from Michael.
Yeah, I really love the Spidergrams as well. It soothes my simple brain, I think. But I also like the fact that somebody or some people are feeding back it's the time issue. Well, we're doing lots of work to, stop people having to go and pathfind, putting data sources on a page, doing a learning event so that nobody's obliged to go out and figure out how to do it. It's all been done for them.
So well, just before we move on to the next question, just in terms of timing, I'm just thinking, but some of the smaller ones, there's some people doing some really good stuff, and while there might not be you might not be an expert yourself, somebody in your practice or in your neighbouring practice that is part of your PCN might be an expert in some of this. Find out what your everybody else in your PCN is using it for. Ask the questions. I'm sure they'd helpfully share and show you. But there's definitely some really good work that's going on. I'm sure you'd both agree, Michael and Wakas, from these. Should we move on to question 3? We got to the 80, so my target was reached.
We need to do it again now for the last one. Come on, let's go to 80.
I suppose just whilst that's ticking over, and coming back to the time issue, I'd be curious as to who is actually looking at it within practices. Is it the practice nurse? Is it the partner? Is it the practice manager? And then in teams likewise. And when are they doing it? Bob spoke about it being refreshed about every 3 months. So when are they looking at the data? Again, keen to hear in the chat from teams about how they and when they're using it.
Some really good ideas here, Michael, for you for the development of the tool. What people want to see, they want to improve. 55. Come on, fastest finger first.
Michael, somebody's put their young T2. I think there's something coming up on the young adolescent dashboard, isn't there?
So that was something that Bob spoke to about the variation in care and possibly that there are the care provided to people with young type 2 diabetes. The care process isn't equivalent to that people of older people with type 2 diabetes. So that's a possible priority that we need to look at, whether that be regionally or nationally.
Brilliant. I think that probably is where we're going to get the maximum numbers, and I think it just highlights common things that do matter to us as clinicians as well, where we're seeing care processes, targets, all of those sort of socioeconomic factors that we look at, whether it's ethnicity, deprivation. You've mentioned the young people with type 2 diabetes, and then on the peripheries we've got some different things around urine ACR popping up, which I think it's like an ongoing problem, I'm going to say, how we boost that across regions. And I think some of these things, like you said, is through the presentation with Bob, they've been highlighted. What are the things that you can look at? And probably majority of them are already covered within the dashboard. But there are probably a few things, like I can see reducing insulin errors, maybe how we pick up data, and also what data is available within the care records to pick it out of System 1, EMIS and Vision and all the different things that we have at our disposal. Brilliant.
So just before we wrap this bit up in terms of time, so Michael, I'm going to ask you, what's your favourite part of the dashboard? And Wakas, we know yours, it's the spider diagram. I'm going to ask you, what would you most like to improve? Because both of you two haven't done the Menti, so we'll put you two under the spotlight quickly.
I suppose for me, my favourite part, if you like, is the fact that you're able to drill down and explore subpopulations a little bit. So you can explore by deprivation, by age, by sex, and start to identify, are there inequalities in the delivery of care that mean that some populations are getting better or worse care than others, to be able to say, well, okay, we need to focus on some work on that particular part of the improvement piece.
Brilliant. Go on then, Wakas. What if I give you a magic wand, what would you want adding?
I think alongside the data, I think what might be useful for me personally are probably just 2 elements, or one element is probably that would be around therapies, medication and prescribing. So we know what types of treatments, therapies people are perhaps using. The other thing where if it would personally for me is I always look at that sort of cardiometabolic space, where we're looking at people with the lens of long-term conditions, multi-morbidity, rather than in isolation. So for me, one of the things perhaps would be, for instance, with type 2 diabetes, what other comorbidities do they have? So around ischemic heart disease, stroke, hypertension, CKD, obesity, the things that matter. And if we were able to see that with outcomes, with care processes, and then have some prescribing data built into it, will probably give you a really good picture in terms of, are we using the right treatments for the right patient or right cohort, and is it giving us the right outcomes as well? And that gives us a really good longitudinal view as a system in terms of perhaps, within the NHS, which type of cohorts should we focus on, in a bit like precision medicine. So very targeted precision medicine and what that looks like. But yeah, that's my sort of crystal, if we do have anything. But thank you, everyone.
No, I think your point there about multimorbidities is really important there, Wackers, because by its nature it is purely looking at people with diabetes, but many of those will have those comorbidities. And so if we can start to explore that a little bit more, I think that'd be a really important development.
We've just got a couple of questions in the chat. Are you all right if we do them now?
Yep, if we can.
Yeah. So Maggie has said in the chat that her team's been working with the NDA team, NHS England. In fact, Maggie is here now. Maggie, do you want to go ahead and ask your question?
Yeah, and this probably shows my naivety about the NDA and what's included and how to do it. But we know that our patients with monogenic diabetes are poorly coded, despite the genetic results going to their local clinician. And we were hoping to provide data by NHS number. And therefore, we'd know that that particular diagnosis would go back appropriately. But obviously, there's an issue with identifiable data. So everything you've shown has been kind of anonymized. So I just would welcome any thoughts on how we might get around that. We could provide genotype by GP surgery or healthcare provider. That would be an awful lot of work, but we could provide it. But then we'd still have the problem that those patients weren't well coded in their own practice if we didn't feed it back. So yeah, just any thoughts welcomed. I know my colleague's been working on it with the NDA team, but unfortunately she's on leave today. But any ideas welcomed.
I'll let Bob come in.
Maybe I should just answer that. There is a project ongoing to link the National Register of Monogenic Diabetes in Exeter to the NDA and to produce a specific report on monogenic diabetes. So that issue is presently being addressed. As usual, the factor that is slowing down progress is overcoming all the ID issues, but I believe it may not be too long before we have the data that would allow production of relevant reports.
Yeah, so Bob, I'm with the Exeter team, but the query we've been left with is the kind of, what's the word, the problem about it being identifiable, and do we need consent then from each one of those 4,500 individuals for their data to be linked by NHS number? So I just didn't know if we'd got any solutions to that.
My understanding was that there was progress being made on that, but
okay.
I hope I'm not being over optimistic. That was the last I heard.
Okay, no worries. Thank you.
And John, I think you had a question.
Yeah, sure. I suppose that it was the first slide that sparked the question in my mind, which was showing that the prevalence of diabetes was 5 or 6 and rising, and it was that of 10% in America, and at the moment there didn't appear to be anything that was going to stem that rise. And we had a discussion yesterday with the diabetes programme team in Humber, North Yorkshire, and I was saying that how would we know if we are, and I apologise for the analogy, if we are winning the battle against diabetes across Humber and North Yorkshire? And if we were to present that to our ICB board, either to go for more resources or to give them some feedback that what was being invested was working, I was aware there's lots of little battles going on, whether it's prevention, whether it's type 2 and pulling them back to not being type 2, whether it's treatments. It's very difficult when there is so much data to knit that into a story that you will be able to take to an ICB board, because not everybody is into coloured charts and numbers and tables. And I'd really appreciate a discussion with others, not now, but in the future, is about if we had to present a story that conveyed the diabetes health, whether it was at PCN level, whether it was at practice level, or whether it was at ICB level, what would be the most important statistics that we would use, and how would we use them to give, you know, how boards like to see things as red, amber and green. How would we use that statistics to come up with something very simple to say to an ICB board, actually, you're on top of diabetes, you're green, or we're not sure if we're on top or not, or you're just on red. We're actually losing this battle. There's too many people becoming diabetic because the prevention programs aren't using. And I'd love to engage in that kind of discussion as to which of these statistics are of more value than others that we could use to convey a simpler story to those whose first line of interest is not diabetes, but who may control the resources to be able to give them a sense of some of the decisions that they might need to make. There's no answer, but I'd appreciate the discussion in the future, or an opportunity to engage in that discussion in the future.
John, I think that it's a great question, and I think that it's possibly the answer would be a trailblazer answer as well. So I'm more than happy to sit down in a room with you and try and figure out a way forward. And I think if there's any volunteers out there that are on the line today, then everybody's welcome, and we can maybe get together. I'm really happy to pick that up with you. Yeah,
I'm quite happy to be a trailblazer answer. I've never been one of those before. I don't know what it is.
We can do a mind map while we're there, so that would be good. We'll pick that up. I think Bob's got his hand up.
Yeah, just to address that. I mean, I think it gets to the heart of the whole of this diabetes data issue, is trying to understand the question that the audience want answered. And the question that the ICB board will want answered will be very different than the question that an individual general practitioner or a person running a specialist service will want answered. For me, one of the big steps forward would be trying to better understand what those questions are, and to provide little roadmaps from the questions to the relevant data, so that anybody can take that question and in their own environment navigate themselves to the relevant answers.
Michael?
Yeah, I suppose I was going to come back. Forgive me for coming back with a question, but would you see that as being a single set of metrics that would act as a kind of ongoing dashboard, or some pre-work that happens outside the room where somebody has made in your words, a story out of the 40-50 metrics to say this is what's happening in Yorkshire and Humber? I guess getting a sense from the ICB board as to, is it a fixed set or more of a kind of processing of the data so it makes a kind of coherent story, an accessible story, whether that would be more useful. And just because that latter piece of work is work that we did do with Northeast region and looking at foot care to create a story from all their foot care data, if you like.
Michael, are you
Just-
asking me the question, or I'm happy to answer it?
John, I'm just conscious of time. I wonder if it's Michael's posed it, and that kind of that's something that you can have a think about, and you and Caroline have that conversation. Caroline can feed back to Michael.
Sure.
If there's something that we can do. Just really conscious. I don't think we've got through all sort of all of the Menti, and there's certainly the evaluation in the chat. Do you want to quickly flash up the Menti maybe, and then if people have to go, they have.
Just before we do that, there's just one final question from Richard. He's asking, when will the dashboard be updated with 22-23 data? It might be a quick one to answer.
So the next quarterly data, which takes you to the end of March this year, will be out in August, I think, and then the core annual dashboard data will be as soon as the integrated data is processed. It's all in now, it's being processed. It will be, well, I don't know exactly when it will be. We'd need to ask the analysts, but they're working on it and trying to get it out as quickly as possible.
I was actually just about to update in the chat on that one. Sorry, hi everyone. I'm Ella. I work in the NDA team, so I'll just post that in the chat. But as Bob says, the data up to the end of March 23 on the quarterly dashboard, that's actually just been released this week. It's been updated on the dashboard this week, so you should see up to March 23. And then for the core annual, we expect that to be towards the end of the calendar year. As Bob said, we've got all the data in just about, but it needs a lot of linkage and analysis before it's ready to be updated in the dashboard. So towards the end of the year for that.
Thanks, Ella.
Thank you, Ella. I was just wondering, I'm conscious of time, and we probably do need to wrap this up for colleagues over the lunch breaks if they've managed to have one. Dan, how many slides do we have on the Menti left?
Just this one, just to finish
it's
off.
Just this one, yeah. So this was just really to gauge, and obviously we'll send a feedback question in terms of what colleagues might wish to see in the future, or how do we wish to sort of plan. This is just a taster. I call this our taster session as a learning around data. So what do we wish to do next as well would be really, really useful for this. I'll let Bob come in and then we'll hopefully end it. Bob, please.
Just in respect of feedback, every single dashboard has got a feedback button. So when people are using them, please feedback using that button. Just press the button, you'll get a short questionnaire that you can use to articulate your requirements. Please use it.
Thank you, Bob. That's very useful. And once again, just thank you to colleagues for attending and giving us your time, and hopefully you found it very, very useful. And like I said, we'll just send a question or a feedback questionnaire around. So please do put any queries in it as well. And hopefully with that, we'll just then scope up what might be a second event. It looks like there is a lot more to do here. And this just gives you a flavour of how we could all use the NDA and the different dashboards that we have around looking at data and focusing on data-driven outcomes. And with that, we'll bring it to an end. And thank you very much, everyone, for listening and being here. Thank you all.
Thanks, Wakas. Thanks, Dan. Thanks, everyone.
No, thank you, Wakas. Thank you, Bob.